Good afternoon, everybody, and welcome to the first APSAD and webinar series for 2018. It's an honour to be invited to talk about the subject of medical cannabis. I assume many of you already have a bit of an understanding around medical cannabis issues, so I'm not going to spend a lot of time going over them. Well, I will touch upon some issues around medical cannabis, regulatory frameworks, and just what do we mean by medical cannabis, with a view then to, before I really get into what I want to be focusing on about, is how this impacts upon us in the drug and alcohol or addiction sector. You'll see my organisational affiliations there on the slide. All right, so look, I just wanted to, in this talk, just wanted to acknowledge the immense contribution of David Alsop to this whole area of medical cannabis and the addictions. David was the first one that really got any of us interested in medical cannabis for cannabis use disorder treatment. Some of you may know that David has been quite unwell recently and has actually pulled out of work, and I think many of us would wish him well. You can see there my some of my conflicts of interest with regards to funding. Received very little funding from governments or NHMRC for medical cannabis related research. I don't think anything I'll be talking about today is everything that I'm referring to is disclosed where the data comes from. So in terms of presentation, I want to provide a quick overview of medical cannabis in Australia, talk about the pharmacology regulatory models and what kinds of products are currently available. And then I want to spend some time looking at the issue about cannabis use disorder developing in patients who are using medical cannabis and what this means for us as a treatment sector. So I like to think of that sort of a little bit like if we're thinking about patients using opioids in chronic pain treatment. Some of those patients, a minority of them, will become opioid dependent. So we've got similar issues going on with medical cannabis, that many of the conditions are long-term chronic conditions. A proportion of patients may well end up using cannabis long-term, and a proportion of those will end up having a cannabis use disorder. So I'm just going to explore what some of those issues are for us in addiction medicine. And then I want to finish up by actually looking at how we may think about harnessing the cannabinoids and medical cannabis in the treatment of substance use disorders, with a focus on cannabis, alcohol and opioids. That's an overview. What I might do is just pause at the end of each of these three sections, throw it open up for any quick kind of questions, and then move on to the next section. So a quick overview of medical cannabis. I'm going to whiz through these slides simply because I hope many of you have sort of either seen them before, seen something similar before, or should be generally familiar with many of the issues around cannabis. So for those of you, the cannabinoids work because we have an endocannabinoid system. There are CB1 receptors, cannabinoid 1 receptors, and CB2 receptors are the ones that we know of at the moment. CB1 is largely brain, gut, and respiratory. CB2 tends to be more immune system. Our bodies also produce endogenous cannabinoids. So we've got cannabinoid receptors. We then manufacture our own cannabinoids. Anandamide, 2-AG are the most well known, the endogenous cannabinoids. And there's a whole range of enzymes, FAR, DAG, MAGL, and so forth. These are cellular enzymes that metabolize the endogenous cannabinoids. So in terms of the future research directions, there are some research groups that are actually targeting those enzymes. So think of SSRIs. You want to increase serotonin levels, and you do that by inhibiting the reuptake of serotonin. Well, there's some similar kinds of research approaches going on with the cannabinoids. You know, can you change the cannabinoid system by influencing the metabolism of the endogenous cannabinoids? Of course, another way of impacting upon the cannabinoid system is by using exogenous cannabinoids. And there's two sources of exogenous cannabinoids, either plant-based or synthetic. THC is the best known of all the cannabinoids. THC itself is a partial agonist at the CB1 receptor system. And the CB1 receptor system has most of those psychoactive effects that we would be familiar with that cannabis produces. Now, THC can be derived from a plant, it can be made synthetically. The cannabinoids are not difficult molecules to make synthetically. Indeed, they're incredibly much cheaper to make synthetically than to try to extract from a plant. And as we know, THC produces a range of psychoactive and physiological effects. Working in the addiction sector, I think most of us will be well aware of what the effects of THC are: sedation, euphoria, cognitive performance effects, some impact upon memory, reaction time, and so forth. And there's a range of physiological effects as well, and noting that it can also have some antiemetic, analgesic effects, and so forth. The pharmacology in terms of the kinetics has poor bioavailability when taken orally. It's not great even when it's inhaled. You'll see the graphs there on the right-hand side. The top graph is what happens when you smoke cannabis, and the bottom one is what happens when you consume it orally. So if you take it orally, it has slightly lower bioavailability because of first-pass metabolism. But what you see is much longer duration of effects. So it takes longer to reach Tmax. So it takes about an hour or so for oral effects and lasting up to about four hours. Contrast that with vaporizing or smoking, where it's a much more rapid onset, but also less duration of action. THC is metabolized through the liver. It's a number of CYP drugs, although the drug-drug interactions with THC don't appear that clinically relevant. As soon as I say that, I'm sure someone's going to point out that they once saw a clinically relevant drug-drug interaction with THC, but it's not a key feature clinically. THC itself is metabolized very quickly to 11-hydroxy-THC, which is also active, and you'll see that in the graphs on the right. Then the main metabolite is carboxy-THC. That is inactive, so that actually doesn't produce any psychoactive effects, and it is largely carboxy-THC that we detect in the urine. Now, if you're only using acute or sporadic cannabis use, carboxy-THC is detectable for a few days. If you are a regular user of cannabis with chronic use in THC, carboxy-THC will stay detectable in the urine for weeks, generally at least 1 month, can go up to as long as 2 to 3 months. So that's THC. That's sort of the main cannabinoid of interest, especially in the addiction area. But there's other cannabinoids. There are a whole range of cannabinoid molecules in a cannabis plant. The other one, which is of particular interest clinically, is cannabidiol, CBD. Cannabidiol is a non-psychoactive cannabinoid. It has a range of properties that are very interesting clinically: anticonvulsant, anxiolytic, antipsychotic effects, some good animal data around neuroprotective effects, and some analgesic effects as well. You can see the doses of CBD where we're using it clinically. A lot of variation, but you can see it's usually in that 200 to 1200, with most conditions using around 400 to 800 milligrams oral CBD a day. In Australia, CBD is a Schedule 4 drug, although there is no licensed product, CBD product licensed in Australia yet. The first CBD product has been licensed in the US recently. The FDA have approved Epidiolex. There's a picture of Epidiolex down the bottom. That's the GW manufactured medication, and it's been approved for pediatric epilepsy non-responding to first-line treatment. The main interest areas for CBD are epilepsy, mental health, neurodegenerative conditions, and there's a lot of interest in the addiction space, and we'll come back to that. The Pharmacologist CBD, that's a really busy slide. I'm not going to walk through most of it, other than to say this Pharmacologist CBD is a little bit complicated in that we don't really know how CBD works. And as you know, when you don't know what a mechanism of action is, it's really hard to understand the pharmacology. The kinetics of it are fairly straightforward. It has poor bioavailability, again, only 5 to 10% oral bioavailability. And the issue there again is first-pass metabolism. Now, CBD, unlike THC, actually does appear to have a range of clinically relevant drug-drug interactions. You can see the most commonly sort of identified CYP drugs, and CBD is a potent inhibitor of CYP enzymes. So what that means is that other inhibitors will slow down the metabolism of CBD, and CBD will slow down the metabolism of other drugs that are metabolized through the same systems. Now, this is particularly relevant with some medications that are also CYP enzyme metabolized. They're clinically relevant, things such as phenytoin, carbamazepine, and clobazam. Now, the reason they're particularly relevant is that they're all anticonvulsants, and given that the main indication for CBD in medical practice at the moment is for seizures, you can see there may well be patients being treated with carbamazepine, phenytoin, or clobazam for whom CBD is added, and then actually you have to be aware of the drug-drug interactions there. In terms of pharmacodynamic effects, you can see there, as noted before, the anxiolytic effects, antipsychotic, anticonvulsant, anti-inflammatory. There's lots of antis there, lots of good effects. CBD itself actually does not appear to have any psychoactive properties. It does not make people intoxicated. On the whole, there's very little, very poor discrimination of CBD from placebo. So if you give standard doses of CBD to someone, or placebo, on the whole, most people can't tell you whether or not they've just had active or placebo drug. There's no, very little abuse potential and no documented withdrawal and stopping CBD. And if you measure things like blood pressure, pulse rate, again, CBD doesn't really seem to impact on those physiological parameters. And CBD does not even seem to really impact much on the effects of THC, much in the studies, the few studies that have been done. There is thought that adding CBD to THC may reduce some of the adverse events seen with THC, so some of the things such as anxiety and so forth. However, we really need better studies before we're confident about what's going on there. And as you can see in those slides there, in the last comments, we still don't really understand the mechanism of action of CBD. All right, so they're the two main cannabinoids of interest. I just really want to quickly move on then to just mention that cannabis use is already quite common in Australia. So a number of studies of some of the areas which we know people are interested in, such as pain, palliative care, and epilepsy. There's a number of studies that were done a few years ago, 2-3 years ago, where people were surveying in cross-sectional snapshots of those patient populations, and it was remarkable that the sort of same number kept propping up. You know, in one sample it was 13%, in another 16%, another 15%. By the way, that's about, you know, one in six patients with those conditions report using medical cannabis. Now, we've already got some data from the pain population that actually what we're seeing is more and more people are interested in using medical cannabis now, probably because of all the media interest. So this is not uncommon in Australia, that people are turning to illicit cannabis supplies for, and using that for medical reasons. And in all these studies, a recurring theme in all those populations is, you know, when we ask them, and so what made you think about using cannabis for medical reasons? And in almost all cases, it's because the patients were not satisfied with conventional treatment. Either conventional treatment wasn't working, or conventional treatment had too many side effects, issues going on. And I'm sure many of you out there will be familiar, there is very strong community support for medical cannabis being legal. Although it's pretty obvious there that actually a lot of people don't really know what is meant by medical cannabis when they say, yes, it should be legal. Okay, so when we say people are turning to illicit cannabis supplies, what does that actually mean? Now, if we were in Canada or in the US, you'd be able to order your cannabis and have a good understanding of what is in the bag of cannabis you just bought. So, for example, the top figure there is a strain of cannabis you can buy in Canada and in various dispensaries in the US. Go in over the counter and you buy some sour diesel, and the man in the shop there, or the woman in the shop, will tell you the sour diesel has somewhere between 19 and 25% THC, somewhere between 0.1, 0.3% CBD, and some other cannabinoids and some other terpenes and so forth. Or you could buy some Cannatonic, which is the strain below, and you can see that's a lower THC, much more CBD, and there's dozens and dozens and dozens of different variations that you can purchase. Now in Australia, we actually don't have that technology or ability available to us. Indeed, it's fair to say we've actually got very poor understanding of what is in Australian cannabis. The last published analysis was done with cannabis from over 10 years ago. So whilst this was published in 2013, the actual cannabis supplies was from over a decade ago, where some researchers went and got police seizures, and this is what we found. What we found was an average THC content of 15%. You can see a lot of variation. So some samples had almost no THC, others were up at 25%, and the vast majority had little or no CBD. So huge variation in terms of what we're seeing in Australian cannabis supplies, and I guess the concern is that most people have no way of knowing what is in their cannabis supplies. Now, the next slide is a study we've done more recently. This is some work that the Land Initiative did called the Pelican Study, recently published. And it was interviewing a number of families in New South Wales and Queensland who had turned to cannabis extracts to treat their children's epilepsy. And we asked the families, hey, what do you think's in the supplies? And we actually got the families to give us some cannabis supplies of their cannabis extracts, and we analysed them in the lab. And most of the families expected that there was going to be high CBD in their cannabis supplies. And when we actually ran the analyses, this is what we found. And it was a little bit surprising. The majority of these extracts had no CBD in them. A large proportion had THC. And the bottom panel there, panels E and F, refer to some of the less common sort of cannabinoids. So you can see some of them had lots of CBC in them, others had lots of CBG, and this is the variety of different cannabinoids that are out there. So I guess what this slide tells us is that in Australia, there's a lot of people turning to illicit supplies. And one of the consistent themes is there is no way of anyone really knowing what is in those supplies. So this is a bit of an issue when we're sort of thinking that people are using cannabis for medical reasons. Hard to know what's going on when you don't even know what's in the extract that you're using. So that's illicit supplies. Now, how do we access regulated supplies in Australia? Well, one way is you look to what are the licensed cannabinoid medicines. In Australia, we only have one licensed cannabinoid medicine. That's nabiximols or Sativex. It is licensed for spasticity. There's a whole bunch of information around Sativex. It's a 1-to-1 THC CBD formulation. It's an oral mucosal spray. Each spray's got about 2.5 milligrams of each cannabinoid. On average, the average MS patient uses around 6 to 8 sprays a day. So for the average patient, that's around 15 to 20 milligrams of THC a day. Some patients use less, some patients use a bit more, but that's pretty standard doses. The current price in Australia is $250 for a bottle of nabiximols, and you get about 100 sprays. So according to the dose, you're going to be getting something like 1 to 4 weeks supply out of one bottle of Sativex. To prescribe Sativex, it is a licensed medication. You don't need to talk to the TGA. All you do is you get your script book out and you write a prescription. But before you do that, it is a Schedule 8 medication. So you do need to consider what is your local government's Schedule 8 requirements. So will you need a permit from your state government? In New South Wales, for example, the answer is yes, you do. It's a Schedule 8. You have to apply for a special permit. In the same way, if you're in New South Wales, if I wanted to prescribe an opioid, oxycodone, for an opioid-dependent patient, for example, I've got to put in an application. It's the same with prescribing Sativex for any indication. Now, if you're going to prescribe it for non-MS patients, then generally what we say is follow the off-label prescribing professional standards if you're going to do off-label prescribing. So most colleges will describe the kinds of professional standards they expect their fellows to follow when it comes to off-label prescribing. I won't go into that unless there's any particular questions around that. Then the other thing you would have been hearing about in the media, and some of you maybe have accessed, is the issue of the unlicensed cannabis product. Now, some people keep going on about this special things that have been introduced to Australia. The reality is there is nothing new about this. We are following an existing regulatory framework for using unlicensed medicines in Australia. There has been nothing new created for cannabis products. So if you want to prescribe an unlicensed medicine in Australia, you can either do a special access scheme or an authorised prescriber or a clinical trial. Now that's the same if you're using an unlicensed chemotherapy drug, an unlicensed cannabis product, or an unlicensed, any unlicensed medicine. What the TGA has done is that they've gone and assessed and fast-tracked a number of products, cannabis products, that they've already gone and assessed as meets their requirements for quality production for standard product, and they've already assessed them and said, yep, here is a bunch of medical cannabis products that we're happy for clinicians to start using. And so they're basically supposed to make the process a little bit easier. The other thing that's happened now is most states have gone and linked the special access application to the TGA to their local state health department, so that you're only having to put in one set of applications. But I would suggest check with your local state health department, because each jurisdiction is doing something slightly different as to how they are linking up the Commonwealth TGA with your state health department requirements. Now, again, none of these products are subsidised by the PBS. They're unlicensed products. You cannot have an unlicensed product subsidised by the PBS. And most patients are having to fork out about $10 to $20 per week for a THC product, much, much more for a CBD product. CBD is much more expensive. Now, also what we are seeing is increasingly more and more capsules, tablets, extracts in oils and drops. What we are moving away from with less and less and less uptake is plant matter, where you get a bag of cannabis plant. For a range of reasons, it's really difficult to handle plant matter. Difficult to store, difficult to dispense, difficult to prescribe, difficult to regulate, difficult at lots of levels. It is so much easier for us as doctors to prescribe a standardized product like tablets or capsules. It's easier for pharmacists, it's easier for patients. So I think what we'll be seeing more and more of in Australia is sort of a standardized product like a normal medicine, rather than us prescribing, half a gram of cannabis to be vaporized per day. That I think is not going to be common in Australia. And generally what you have an option of is either THC only products or combinations of THC, CBD, or some CBD. Now, if you want to get more information about what these products are, I refer you to the website, the Australian Government website. It's the Office of Drug Control. You hop on here and it's got everything you need to know as a doctor, as a patient. Pretty much this walks you through the whole lot. You will walk through and see the kinds of products that are available. So this is just one website. Sorry, I'm not trying to advertise for these companies. It's just a page that I pulled up the website. And so, for example, you will see the first one there is Health House International. They have got 3 products at the time that I downloaded this. It might be different by now. And you can see they have a product called 1 to 20 Cannamide oil. That's THC 1 milligram per mil, CBD 20 milligrams per mil. You can buy a 60 mil bottle of that, and you can figure out how much THC and CBD is in that. And if you want to use that product, you ring up Health House International, you contact them, and you speak to their provider, and then you start your TGA special access application. So now there are over 30 products on this website that you should be able to go in and start using. And you contact the local companies, and they'll give you a sense of price and so forth. All right. So that's what the products are. If in Australia, if you want to get a sense of, where do I find some guidelines and some guidance, the TGA have put out some guidance around the use of medicinal cannabis. If you search medical cannabis guidelines TGA in Google, this will come up like a rash. In here, you'll find a whole bunch of generic guidelines around prescribing medical cannabis, some good practice tips, and they've got specific guides for epilepsy, nausea, vomiting, MS, and palliative care. Now, in there also, there's a group of researchers from Endoc have done some systematic reviews of different areas of evidence. There's some other sort of standard systematic reviews. These are considered like the gold standard that have been done. So there's the TGA reviews. There's the JAMA paper from 2015, very high quality systematic review. You can see there sort of the kinds of areas where the data is, and you can see most areas don't have good evidence, low quality evidence in most cases. When it comes to chronic pain, the JAMA paper summarise the chronic pain. You can see their meta-analysis was that it was just favourable in that cannabis use works better than placebo. There's the National Academies of Science systematic review. They summarised their evidence in sort of this snapshot here, where they've said, there's good conclusive evidence for the conditions on the far left, and if you go over to the far right, you'll see areas where they say at the time of writing that there wasn't good evidence. So you can see there's a slight variation from one authority to the next in terms of they make slightly different conclusions in some of the evidence, but the evidence is the same. They all go and pull the same papers, the same studies, and informing sort of, these kinds of summaries. All right, so they're the reasons why we might want to use cannabis. Now, also need to talk about adverse events. Most of the world's understanding of the problems of cannabis come from our understanding of illicit cannabis use. Now, we need some caveats in here. So, illicit cannabis use, as you guys all know, tends to be really high potency THC with low CBD levels. It tends to be smoked. And so what you're seeing with smoked, either joints or bongs, is very high concentration, high potency, and often really high doses. So you need to accept that when extrapolating about what are the harms of cannabis use from an illicit population, it's a little bit like saying, let's look at the harms that a illicit heroin user has when they're using heroin. And from there, we will extrapolate back to what the side effects of oxycodone are in a patient prescribed oxycodone for back pain. Now you can see it's not really apples and apples there, but yeah, there's a common factor there in, heroin is an opioid and oxycodone is an opioid, but a lot of the problems of heroin are not going to be the same as the problems of taking your endone. Because as we know, working in the addiction field probably better than anything, the effect of any drug is not just the pharmacology, it's about the drug, it's about the individual using the drug, and it's the broader setting context. So if we want to understand what a drug does, you need to understand all those issues, and it's why we need to take, some of the harms identified around illicit cannabis use and recognise they're an issue, but not necessarily equate that they're all going to be exactly the same with medical cannabis. But anyway, what can we say about potential harms of illicit cannabis use? There is a wonderful WHO monograph that came out 2 years ago around illicit cannabis harms. Wayne Hall was the lead author in that, and I would strongly suggest if you're interested in a good summary of this, go look at the WHO monograph. Most of us know this stuff. We work in addictions. We know the harms of illicit cannabis. There's cognitive problems. Most of those are very short term. They settle down. There is, of course, concern around some long-term cognitive problems associated with heavy, persistent cannabis use in adolescence. And that probably tends to be about the only groups where we can say there seems to be irreversible effects of long-term cannabis use. It tends to be in those individuals who are using cannabis very heavily in adolescence. And we know this from other drugs. Adolescent, heavy drinkers end up having permanent deficits as well. So we know adolescence and heavy drug use don't go well together. The other area, of course, of interest is mental health. There's a lot of interest in, is cannabis related to psychosis? A lot of ink has been put on this. I think that most people have settled on the idea of cannabis contributes to and exacerbates psychosis in those people that tend to have a vulnerability. So there isn't many experts in this area who would argue that cannabis causes long-term permanent psychosis or a functional psychosis on its own. I don't think any experts would argue that. Rather, they see cannabis in vulnerable individuals will certainly exacerbate and worsen outcomes. And so this is relevant. We need to be aware of this. Some of the other harms, dependence, we'll be coming back to that. It's a focus, and there's all those physical. So that's what we can say about illicit cannabis use. Now, when we look at prescribed medical cannabis products, so you can see there's a nice little table from a journal paper, McCallum and Rosso. I think I've got the reference in another slide. And this sort of nicely breaks down what we can expect to be the more common versus the common and the rare kinds of adverse events. Of course, generally, as in most areas of medicine, the rare events tend to be the ones we are more worried about. So some of the concerns around some of the severe mental health problems, fortunately, tend to be rare. The other things we can say around adverse events with cannabinoids, like things such as opioids, most of the adverse events occur early and are transient and generally settle down as tolerance develops. Most of the side effects are dose-related. So a common problem with cannabis is medical cannabis is prescribing too high a dose early on. And generally what you need to do with most medical cannabis in a non-tolerant user, so in a non-cannabis user, generally you should be looking at a 2 to 4 week titration period to reach your target end dose. So you need to slowly increase the dose over a 2 to 4 week period. If you look at medical cannabis trials, and generally we see around 20% to 30% of patients actually drop out of studies of medical cannabis, usually because of side effects. So, we need to appreciate not everyone actually likes cannabis. And I just want to highlight, that's about the same proportion of patients that drop out of opioid studies. So that's not unusual. About 20% of patients drop out of these trials, and they usually don't like the effects of cannabis, basically. Now, of course, a lot of people have emphasized about the concerns around long-term cognition and prescribing medical cannabis. I've always thought this is a little bit disingenuous, simply because not many of us can actually identify really any condition where we would be, prescribing long-term THC-based medicines to adolescents. So most of the conditions that people are thinking about where you would prescribe a THC-based medicine, such as chronic pain, such as palliative care, chemotherapy, it tends to be in older people. So, the concerns around long-term cognitive problems that we, genuinely need to be concerned about with adolescents, probably we're overstating some of those concerns, in my opinion. And if you are going to get psychiatric complications, well, first and foremost, I think we always need to be cautious. We probably shouldn't be rushing in with a THC-based medicine in an individual with a history of psychosis or severe anxiety. especially if it's a drug-induced psychosis or panic attacks, for example. But, you know, avoid THC-based medicines in those patients. If you're going to see adverse events, then generally probably going to have fewer concerns, again, as we said. Slow titration, use low doses, avoid things that are going to result in a high peak concentration. So maybe avoid inhaled routes so you're not seeing the high Cmax, and probably throw in lots of CBD. Because we've got, you know, data suggesting CBD dampens some of the psychotic effects of THC. If a patient, though, is experiencing psychiatric adverse events, then the rule of thumb is stop the cannabis, consider symptomatic medication or treatment of the adverse event, and probably it means THC is probably not a good medication if you are having psychosis or panic attacks or anxiety linked to your THC use. All right. Just looking at the time, I've got time. You know, if there's any questions or point of clarification around the general medical cannabis stuff, because now it's going to go into some of the more addiction-y things around cannabis use disorders and so forth. Tori, is there anything I need to do to?
That's all right. If anyone had any questions, if you could just type it into the chat and I'm happy to read it out. Okay, doesn't seem like there's any questions. So
all right, good. That's all the generic medical cannabis stuff. Hopefully you've seen that stuff before. I now want to sort of move on to some of the stuff which is a little bit more interesting for us in the addiction space. The first issue I really want to talk about is this issue around the idea that we are seeing more and more people who are going to be wanting to use a medical cannabis product for a number of conditions which are chronic long-term conditions. So chronic pain, potentially epilepsy is an area where some people are wanting to use THC-based medicines. Palliative care, a lot of us sort of think, oh, palliative care means they're going to be, you know, patients are going to be dead in a few weeks. I think many of us are now identifying that actually many patients either having cancer or in palliative care actually live for many years. So, so we're seeing a number of chronic disease conditions that people are wanting to use THC-based medicines. And one of the things we need to be aware of is the potential there for the development of dependence to the cannabis. In exactly the same way, we can expect some patients who are prescribed benzos for their anxiety or sleep become dependent to benzos. Some patients prescribed opioids for pain become dependent to opioids. Well, we should be alert to some patients being prescribed a THC-based medicine for a long-term medical condition may become dependent to their cannabis. So, what do we know about this already? In terms of the studies, when we go and look at the RCTs of cannabis products, and no one has ever measured it. So no one has actually set up a medical cannabis study, say for pain or for cancer or for any other reason, where they've gone and actually looked at the development of addiction. We shouldn't be surprised, because if you look at the whole world of opioid treatment, for example, for pain, you know, we're talking about, you know, dozens, if not hundreds of trials of opioids, and very rarely will a drug company ever ask about addiction. So that's not surprising that in the studies that have been done to date, no one's really been paying attention to it. So the studies don't inform us. Epidemiological studies. Well, what can we say? Say, looking at the US, there's been some work done where they go, for example, and pull all the epi data from states, comparing those that have passed medical cannabis laws to those who haven't, blah, blah, all that kind of stuff. And what they've been able to say is that those jurisdictions in those states that have medical marijuana laws, there is a slightly higher rate of illicit cannabis use and of cannabis use disorders. But that's big epi data, and we can't say whether or not that is an increased rate of cannabis use disorders in patients prescribed medical cannabis, or is that a general population effect? So the epi studies don't really help us. When we've gone and looked at surveys of medical cannabis users, well, again, we're a little bit surprised about this. No one's asking. So there's been quite a lot of studies where they've surveyed medical cannabis users overseas, in America, Canada, Europe, and largely none of those researchers have actually asked about developing addiction to the medical cannabis. And that probably highlights that many people running those surveys tend to be pro-medical cannabis, and they're not interested in asking about any bad things associated with the medical cannabis. I mean, that's just a generalization, don't hold me to that, but I've always found it odd. Why isn't anyone asking these medical cannabis patients about, you know, do you get withdrawal? Are you becoming addicted? The only study that we've been able to pull out is the study that we did. Of course, us being addiction people, we ask these questions. So in the chronic pain cohort the Endoc have been running, you will see there, of the people who said that they had used cannabis for pain, 14% of those met ICD-10 criteria for cannabis dependence, and double met for any form of a cannabis use disorder. Again, think about that, folks, because if we think about what we know from general cannabis use, there's this rule of thumb of about 1 in 10, about 10% of cannabis users, illicit cannabis users, become dependent. And here we've got a number of about 14%, so it's not that different. So I'm going to present some data on a survey that we did called CAM16, Cannabis as Medicine Survey. This is coming out in MJA next month, so in a few editions. It was a survey with 1,700 people online. To be eligible, all you had to do was hop online and say, I've used cannabis for a medical reason in the last 12 months, and we asked a whole bunch of questions to give people a sense of who they were. So 1,700 people, 60% male. They were largely employed, 57% were employed, over half had trained at university. Facebook was where they were largely recruited. You can see mental health, pain were the main kinds of conditions that people said was the main reason they were using their medical cannabis, and a smattering of other conditions down the bottom. In terms of who these people were, about half said that they were using cannabis at the time that they started using medical cannabis. About a third said, I had used cannabis, you know, when I was a kid, or, back when I was at university, but I had stopped using, and I started using cannabis again for medical reasons. And about 14% said, I've never used cannabis in my life, and the first time I ever used it was for medical cannabis use. So not everyone using medical cannabis should be characterized as, they're all just stoners trying to, excuse their use of cannabis, calling it medical. As you can see here, quite a lot of people were not using cannabis and actually turned to it for therapeutic reasons. You can see the age progression there. First cannabis use at 18, first regular at 24, first use of medical at 27, and first regular at 29. These people were using cannabis 19 days out of 28. On average 5 times a day, although a median of 3. And you can see about 80% on average of these people, the average was 80% of the cannabis use was for medical reasons. And you can see most people were using bongs, vaporizers, or oral. Now, we asked a bunch of questions that relates to cannabis use disorder. The first was, after regular use, heavy prolonged use, when you stop, do you get any of the following symptoms within several days? And we use the DSM-5 criteria for cannabis withdrawal. These are the symptoms, and you can see there, so 1,000 people endorsed that they had some cannabis symptoms. And the most common one was sleep difficulty. So about 2/3 of people endorsed that they had some sleep difficulty when stopping regular cannabis use. Restlessness, nervousness, anxiety were the other common ones. And when you look at the sum total, how many met 3 or more criteria, It's 43%. So 43% of people saying that they're using medical cannabis experience cannabis withdrawal, according to DSM-5 criteria, when they try to have a break from their cannabis use. That's pretty high, I think. And certainly it's an issue we need to be aware of if we're going to be using and prescribing medical cannabis. We then were interested about what proportion of people would meet DSM-5 criteria for a cannabis use disorder. There you are, there's DSM-5 criteria, you're all familiar with them. We've now got mild, moderate, and severe according to the number of criteria. Now, when we're also, though, thinking about a prescribed medicine or a therapeutic product, some of you will be familiar that DSM-5 allows you to take tolerance and withdrawal out of the equation. So for example, if you're prescribing opioids to a patient and they're using it as medically prescribed, then tolerance and withdrawal are not part of the SUD criteria. So you've got a different set of rules, unless the patient is not taking it as medically prescribed. In which case, that's called, tolerance and withdrawal are thrown back in again. So if we wanted to, how should we measure it with medical cannabis use? Is it really medical? Should we be excluding tolerance and withdrawal? If someone is pulling 30 cones before breakfast, is that really what we mean by medical cannabis? I don't think any of us would prescribe 30 bucket bongs for breakfast, but that's what some people are doing. So how do we identify what is genuine as medically prescribed and so forth? And I think it's really difficult whilst in the world of illicit supplies. I think we kind of probably are going to struggle with that. Look, the reason I raise these issues is because according to how you define what's in and what's out will determine what proportion of people have a cannabis use disorder. So on the far left, you'll see there, if you just went with a traditional 11 criteria, basically what we found is in this cannabis use population, medical cannabis use population, 40% met a cannabis use disorder, and 17%, 16.9% met dependence criteria. That's with using all 11 criteria. If you have your exclusions at the other end of the, so if you take tolerance and withdrawal out of the equation, then the numbers are much lower. It's about half that number meet criteria for cannabis use disorder. So that's quite important for us, actually. We also did some work to look at what are the predictors of cannabis use disorder. Could we identify who's more likely to meet those criteria? We ran a whole bunch of regression models, and basically what we found is probably the most consistent there is the extent to which people are using cannabis for non-medical reasons. So that's the percentage cannabis used as medical. And there's a number of things there as well. I'm not saying these are the definitive predictors. That's much more work needs to be done. But this is the kind of work that we need to start doing, getting a better understanding. If we say something like 10 or 20% of medical cannabis patients might become dependent to their medical cannabis, then we need to be able to identify who those people are. What are the risks? All right. Now, what does this mean for us clinically? I would like us to think about this in the addiction space, to think through the whole idea of how did we get opioids and benzos so horribly wrong in medicine, and can we learn from that? Now, the pain doctors have learned from it. They realised that, opioid prescribing got a little bit out of hand and they had to sort of rein it back in. I think most of us are familiar with this universal precaution framework that some Canadian pain doctors started over a decade ago, and now is sort of getting accepted as the way we should be prescribing opioids. And the idea there is you screen your patients to identify who are those at risk of developing problems. I think it's fair to say we need more research there to identify the predictors, that you then adjust how you provide medical cannabis treatment according to the risks. And addictions, we're really good at this, aren't we? Think about it. You know, patients who we consider to be stable and doing well, we give them more takeaways, we review them less often, we do fewer urine drug screens. The high-risk patients, we do more of that kind of stuff. So this, for us, is like falling off a log. We know this stuff in addictions because we do this stuff all the time. And then the other area we need to think through is, if someone actually is cannabis dependent, medical cannabis dependent, well, how are you going to treat that patient? And it's a little bit like when we identify someone is opioid dependent and they have chronic pain, well, we have to treat that patient differently to the non-dependent pain patient. So one thing we need to think about are the doses. We would all appreciate the opioid dependent pain patient often needs higher doses than the non-dependent patient. And that's probably what we're going to be seeing for our medical cannabis patients as well. So for example, the traditional dose of THC for a non-tolerant, non-dependent patient is usually 10 to 30 milligrams a day. And yet, when we're thinking about treating cannabis-dependent patients, then we actually, the doses tend to be more in that 40 to 100 milligrams a day. So this is where we need a better understanding of, if someone is dependent to their cannabis, how are we going to treat that patient different to the patient who's not dependent? So these are all the issues that we as addiction doctors need to start thinking about. Now, this is what I mean by, could we start applying universal precautions? This is from an author in Canada who started to think along these lines. I won't go through the whole thing here, but you can see if you work through this flow diagram, basically what they come to is a decision point where they say, is the patient willing to consider marijuana? If yes, then determine the risk. If there is a risk, coordinate with appropriate substance abuse or psychiatric resource. You look at the risk benefits and then you consider whether or not it's worth providing that treatment. So this is where we're going to with opioids. And I'm arguing that we should start the world of medical cannabis treatment with this system in place, not let medical cannabis roll out and then 10 years' time try to put the horse back in the stable. Oh, that's a bad metaphor, but you know what I mean. Okay, so that's the key issue. So I guess what my point is, dependence of cannabis is an expected side effect. It's gonna happen, and it's gonna happen in about 10 to 20% of patients, which is probably what we're seeing with opioids and benzos as well. And cannabis withdrawal is gonna be even more common than the full-blown dependence. And that we as addiction specialists, I think we need to step up to the plate and take leadership in these issues. All right, I've got a small amount of time. I just quickly I'm going to whiz through cannabis and the treatment of substance use disorders. So up until now, like some patients will accidentally become dependent to their medical cannabis. I want to now swing to this issue about how are we addiction specialists and in the AOD sector, how do we use medical cannabis products to treat substance use disorders? So the first area that, the first interest here was the issue of, can we use cannabis products to help treat cannabis withdrawal? Now guys, this is the same logic as nicotine replacement therapy for nicotine withdrawal, buprenorphine for treating heroin withdrawal and so forth. Dave Alsop was really the person that drove much of this research. We ran a little study in New South Wales a few years ago, published in JAMA Psych, and we established that Sativex significantly better than placebo in an inpatient double-blind, double-dummy study, blah, 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 that more patients finished the study, finished detox, and there was less severity withdrawal. So, given we know we don't have any effective medications for cannabis withdrawal, this raises the issue of, should we have this as, one of the options in our back pockets for those patients who we know really struggle with cannabis withdrawal? Or you might be thinking, for the patient being admitted to hospital for another procedure, not for treating cannabis, they break their leg or whatever, they're cannabis dependent, and at the moment, we don't do much for those patients other than try to find them, try to do the ward round. These are the patients that are never in bed. They're off the ward, smoking joints, in the smoker's shed. So they're the ones that we struggle with sometimes in hospital. And the question is, should we be thinking about possibly using something like nabiximols occasionally for those kinds of patients? In Southeast Sydney, we're about to start exploring this and how we introduce procedures for our hospitals to be able to have this as an option for our hospital drug and alcohol CLTs. So that's withdrawal. Now, of course, one of the things that we did with the cannabis withdrawal study, we followed people up, and as we expected with most detoxes, most people had relapsed. Not surprisingly, because that's what detox does. So this has raised the issue of, if we know people are going to relapse, is there a role for longer term cannabis agonist treatment or substitution treatment, replacement treatment, whatever you want to call it? I'm using the term CAT, cannabinoid agonist treatment, because that tends to be the flavour of the month for how we refer to opioid substitution. We don't call it opioid substitution treatment. We're calling it, it's opioid agonist treatment. So I've used that language here, cannabinoid agonist treatment, CAT. So is there a role for cannabinoid agonist treatment for treating cannabis-dependent patients? So there's been some interesting work, small studies, or done in America. We got a grant and we ran this study, just finished. So we've presented this at some conferences. It hasn't been published yet. So please don't disseminate this data anywhere. But for your benefits, you can see we ran a parallel group RCT, about 128 patients made it into the analysis. You can see what we did there in terms of the treatment retention. It was nabiximols placebo, no difference in retention between the two groups. You can see the doses that we were using is about a mean of 20 sprays a day, which is about 20 times 2.5. So what was it? It was about 60 milligrams, I think, in the end. I can't remember. The mean was about 50, 60 milligrams a day. Double the standard dose that we use for non-dependent people. So this is what I mean by, when you're treating a cannabis-dependent person, 10 milligrams of THC, which works in a non-dependent person, is not going to be enough. We're going to have to use higher doses. And we know this stuff, treating addiction, what we expect. So what were our key findings? Our key findings were significantly less cannabis use in terms of cannabis use phase in the nabiximols arm. And these four graphs all pretty much demonstrate that. So significantly fewer cannabis use days in the nabiximols arm than the placebo. And so I'm just looking at the time, and the general conclusion here was that nabiximols was effective in reducing illicit cannabis. This is the first RCT to demonstrate this. One RCT does not make an evidence base. We probably need some replication studies, but I think there's a lot of interest in pursuing this work, especially for those people that try conventional treatments for cannabis dependence and really struggle. I'll just finish up then very, very quickly. Cannabis for opioid use disorder, lots of interesting animal work, some laboratory studies, but we still actually don't have any good clinical RCTs to date. There's a study, some lab work, which showed that dronabinol, which is a synthetic THC, at big doses, so 30 milligrams, was better than placebo and in the right direction, but not as good as giving someone oxycodone, 30 milligrams. So, you know, cannabinoids are good, but they're not as good as giving someone an opioid. If you want to alleviate opiate withdrawal, there's a lot more work that needs to be done. And there's a lot of interest also in this area that, as we know, working in methadone, there's a lot of people that use cannabis to avoid using other more problematic drugs whilst in methadone. I just want to highlight down there that whilst quite a lot of people responded to our CAM16 survey saying that they were using cannabis to treat their addiction. This surprised us, actually. Didn't know that this was already happening in Australia. But there you go. There's also a lot of interest for CBD, for alcohol and amphetamines. We're about to start a study in Sydney looking at CBD for alcohol withdrawal. And Sydney Uni is leading that study along with Sydney and Southeast Sydney LHDs. And there's some interest in using CBD for stimulant disorders. It seems to work very well for methamphetamine dependent rats. So we're keen to see whether or not can we translate some of the animal data into human work as well. So you can see there's a lot of excitement about where the cannabinoids might have a role in, you know, as a therapeutic agent. A lot more work needs to be done. And I just want to conclude, oh yeah, 2 minutes over time, not bad for me. So as addiction specialists, you know, we should have a role in influencing how the treatment systems roll out in Australia. We need to be aware that a significant minority of patients will develop a cannabis use disorder from their medical cannabis use. We need to be thinking about how are we influencing medicine in our, you know, with our colleagues, for us to sort of be thinking about a universal precaution approach from the outset. Not sort of, you know, just letting the systems roll out and then realizing, gosh, we've got a lot of, you know, addicted cannabis patients. You know, we should plan ahead. And then ultimately, what is going to be the role of medical cannabis products, you know, as a treatment for substance use disorder? And, you know, in particular, I think the easiest, you know, the most obvious area is should we be, you know, pursuing the cannabis agonist treatment for those people with existing dependence. And at that, I'm going to stop talking and throw it open for any questions if there's time.
Okay, so we will now begin the Q&A. Just a reminder, you may still submit questions through the questions pane on your control panel, and I'll be reading them out. If you wanted to answer, Professor Lintzeris, are you ready?
Yeah.
Great. Okay, from Jennifer De Lima. Excuse me if I get any words wrong. Are there serum urine levels that may assist with expectation of therapeutic effect?
Can you just reread that again? Are there what?
Are there serum urine levels that may assist with expectation of therapeutic effect?
Okay, all right. So probably not. Urines and cannabinoids are really problematic. So unlike drugs like amphetamines, opioids, and so forth, there's a pretty good relationship between recent use and detection in urines. The problem with the cannabinoids, all of them, they are so lipid soluble that they accumulate in lipid and they slowly are released over time. So if you are a chronic regular user, you can get positive cannabinoids showing up in your urine for weeks and weeks and weeks and weeks. And it is not it's not a linear decay. So what I mean by that is you might have a quantitative level this week, say 400 nanograms per mil, without using again, without using, you come back next week, you could give a urine and it could be 450 nanograms per mil. It's gone up. So urines are clumsy in terms of understanding therapeutic levels for the cannabinoids. Cannabinoids, can I suggest, are a little bit like opioids. It's less about the kinetics and it's more about the dynamics. If you want to know what a cannabinoid is doing, worry less about your plasma levels and look at the clinical effects. It's a little bit like opioids. You know, we rarely ever do. Think about it. There's almost no role for therapeutic opioid levels, and that's probably where we are with the cannabinoids as well.
Okay, next question. Michael is asked, with Australian Doctor magazine reporting that there are clinics hot off the press ready to roll out multi-site clinics just for cannabis, how will we or anyone be able to lead the discussion?
Look, very good question. How do we have a say in a role? Well, so there are lots of ways of influencing these things. So participating in position statements, you know, the college, for example, APSAD, you know, what is drug, is there a consensus position around what we should be doing with medical cannabis in the addiction field in Australia? And I would argue we've never had those debates, we've never had those discussions. I think there's a lot of polarity in the space of medical cannabis. Guys, we should not be surprised that private medicine is going to step up and run with this, because that's what private medicine does. I know in drug and alcohol we are shielded a little bit from the realities of private medicine. We tend to work either at government sector, NGOs and so forth, but the real, you know, is this is what happens. You know, most innovation and nimbleness happens in private practice, not in clumsy government sector. So it was always going to be the case that you're going to get private practitioners who are going to run with this. So that's not a surprise. I almost could not see anything else happening other than that. And anyone thought that we were going to control medical cannabis was dreaming. I mean, it was never going to happen, because that's just not the way medicine happens. So no, we're not going to overly control and tightly manage it. So for example, nabiximols is a good example. At the moment it's a Schedule 8. The company is actually looking to reschedule it as a Schedule 4. If it got a Schedule 4 listing, then you need no approval from anyone to prescribe nabiximols. There will be no regulatory oversight at all. It'll be like prescribing any other medicine, like an antibiotic. And we have to ask ourselves, and is that a problem? You know, we prescribe benzos as Schedule 4s. Of course, many of us would argue, boy, we've messed benzos up. But, you know, in context, the cannabinoids are probably safer than the benzos in terms of, you know, from a pharmacological perspective. So, yeah, look, it's a really interesting thing. The cat is getting out of the bag. The idea that we are going to overly tightly regulate the cannabinoids, I think medicine needs to realise that our ability to do that is limited. And if we try to over-regulate it, then we will see in Australia what happened pretty much everywhere else in the world. They will bypass the doctors. I mean, that's what's happened everywhere else. Largely medical cannabis in America, in Europe, in Canada, has largely occurred by bypassing the health profession, because the health profession didn't really engage.
Okay, I've got a few more questions. Some people are asking if they can have a copy of the slides. If no, can they have a copy without containing your unpublished data?
Yes, certainly. So I'm happy. Yeah, there's a few slides there that I would take some of the data out. Not many, and I'm more than happy to make them available. And can I just check, how do I make those available, Tori? Do I just email them to you?
Yeah, just send them to me, and then I'll send them to our webinar lady, and she'll distribute them.
Perfect.
Great. Okay, next question. Thanks, Nick. Evidence of opioid sparing effects in medicinal THC users. Are you convinced?
No one should be convinced because the data isn't there. So there's a beautiful review that Susie Nielsen led. It's been published, where we pulled all the animal work and all the human work looking at opioid sparing, and as in many areas of cannabinoids, the data just isn't there. I mean, it's not that the data suggests it doesn't. The data is just bad data. I mean, the studies haven't been done well, especially when we're talking about human work. So what we've got is lots and lots and lots of indirect evidence. We've got some epidemiological work. Many of you would have seen the epi data where they, looked at jurisdictions in America with medical cannabis and those without medical cannabis, and they're looking at overdose rates and all that kind of stuff. That's all interesting work. It's teasing, it's interesting, but the evidence is, I think we've got to be really, let's call a spade. The data is not convincing either way, and it's another thing that we got to do more work on. As clinically, I think we've all seen it, haven't we? We've all seen patients, well, maybe not all of us, but many of us have seen patients that will describe they don't need the opioids anymore. Why not? Because they're basically now using cannabis instead. But again, lots of individual cases and anecdotes does not an evidence make. So there probably is something there. It probably works in some patients with some kinds of pain conditions, blah, 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 blah. I think, there's a lot more work that's got to go.
Okay, a few more questions. If titrating up to commence RX, does withdrawal take into account titrating down versus abrupt cessation, withdrawal versus discontinuation?
Yeah, very good question. And that's the kind of stuff that we as addiction doctors need to be driving the agenda on. So, for example, if a patient was on a medical cannabis product for a long period of time, well, we should never recommend just stop the drug. We should be recommending a tapering down phase. And that's the kind of stuff that it's that kind of clinical information that we need to be making sure is going into guidance around how to use medical cannabis products. To date, you'll find, again, we don't have that level of certainty in our documents, in our guidelines in Australia. But if you pull some of the guidelines from overseas, you look at some of the Canadian guidelines, the Israeli guidelines, a lot of those guidelines don't really even mention withdrawal from cannabis. So yeah, I would have thought that, yes, we should be thinking about, tapers, not sudden cessations.
Okay, next question. With OAT, we are reducing injecting and overdose rates. What would be the hard measurable benefits of CAT?
Well, let's be really clear. One of the benefits of OAT is reducing injecting. It's only one route of administration, yeah? Because now, if you looked at, say, in the US, the majority of people entering OAT are non-injectors. They're actually, OxyContin addicts. So, route of administration is a really important thing. Dare I say, that is also one of the benefits of cannabinoid agonist treatment. So, the average punter entering our Sativex RCT was bonging 2 to 3 grams of cannabis a day. And that's bongs. So one of the things we have to ask ourselves, is it a good outcome if you took a patient who was bonging, using water bongs or joints, smoking with tobacco and so forth, is moving on into an oral product a better thing? And I think most of us will say, yeah, route of administration certainly is one thing. What are the other potential, benefits that you see with opioid agonist treatment? Well, one of the things is, why don't we call it substitution anymore? The reason we don't call it substitution is because it's not just about giving them the drug. That's why we've moved away from referring it to substitution treatment, because that just makes it sound as though you're just swapping one drug for another, you know, the old mantra about what's wrong with methadone. Well, I would argue methadone is a heck of a lot more than just swapping one drug for another. You get your healthcare wrapped around, some psychosocial interventions. You're moving to a safer route of administration. You're actually moving away from, hopefully, drug networks, dealer networks. The other thing you're starting to do is controlling, you know, dose levels and things like that. So it's easier to not be, you know, using it. It's like, trying to use the analogy, say nicotine replacement versus smoking cigarettes. So, of course, the harms of cannabis dependence are nowhere near as severe as heroin dependence. So the underlying condition is not as severe as heroin. At the same time, I think many of us would say, well, it's as severe as nicotine dependence, and no one is saying we shouldn't be doing nicotine replacement. No one says that. We're all supportive of that. Well, I would argue there's not much difference between a cannabinoid agonist treatment and nicotine replacement. The rationale. We did find some other things which I haven't gone into now. So we found crime went down in the Big Smiles patients, placebo and that kind of stuff. So, safer route, improvements in general health, greater access to healthcare, counselling, taking them out of drug networks, less crime. They're all the kinds of harm reduction-y type, arguments that we've used for methadone and NRT.
Okay, so we've got another 4 questions to go. So, opioid sparing and opioid OD reduction in some US states where medical cannabis available, I think.
Yeah, so that's the epi data that we were referring to before. Yep. Epidemiological data, it's nice, but it's big data. It's as good as the data that goes in. There's lots of variables. It's really hard to address all the confounders. You rarely ever find only one thing changed. So what I mean by that is, in society, there are lots of things that will impact upon opioid use and opioid-related harms. Medical cannabis laws are just one of them. Have you introduced, education programs for your doctors? Have you introduced opioid stewardship programs in your ED departments? Did you introduce prescription monitoring? Have you changed the pack size on your drug? Do you get what I mean? There's so many things that will impact upon opioid-related harms. And yes, those studies tried to factor as much as they possibly could, but an epi study is just an epi study. It's good, it tells you certain types of things, but we should be cautious about extrapolating to say we've got good evidence that if I prescribed a cannabinoid for my pain patient, I should expect that they will use less opioids. And that's what we mean by opioid sparing. And we don't have that evidence nailed yet. We haven't got those studies done.
Okay, next question. Are there the same conclusions for CBD as well as THC, or is that there is just very little research on CBD, so it is not known?
Oh gosh, the conclusions. Look, CBD, so look, if we just step back a bit about CBD. Think about CBD, pure CBD, essentially, it's sort of going to be regulated in a very different way. It's already a Schedule 4 medicine, so it's not a Schedule 8 drug. And it's non-psychoactive. So we don't have the concerns about are people going to get addicted to CBD? The answer is no. Are people going to overdose on CBD? No. Are people going to end up in ED with a psychotic reaction to CBD? No. None of that stuff. All that is THC stuff, not CBD stuff. Of course, the media doesn't differentiate often about CBD or THC. They wrap it all up into medical cannabis. And so that's where we as clinicians need to understand that CBD is a fundamentally different product to THC. And once we have a licensed product in Australia, so Epidiolex probably we expect will be licensed as a medicine sometime in the next 12 to 24 months. Then we will be able to start to prescribe CBD without any special access, any of that kind of stuff, just as another medicine, on label and off label, and we'll start using it for a number of conditions. The thing about CBD, it's a bit expensive as a medicine if you want a plant extract. Relatively cheap if you make it synthetically in a bucket in the laboratory. And I think that's what you're going to end up finding. Most of the cannabinoids in 10 years' time, guys, I think we're going to see a proliferation of synthetic cannabinoids and not plant-based ones. Simply because it's just too bloody expensive to grow a plant and to extract the THC. THC kind of is THC, a molecule is a molecule. There's a whole world of argument about entourage effects and all that kind of stuff. Into another discussion, but with CBD, my expectation is that CBD we will be flooded with synthetic CBD products within a few years.
Okay, do you think that those who bypass professionals are among people who might use MC?
So, can you just repeat the people that bypass?
Do you think that those who bypass professionals are among people who might use MC?
So currently now in Australia, the majority of people who are using cannabis for a therapeutic reason are sourcing illicit cannabis products, and their doctors and their health providers are not involved in any of that work. So that's the historical background. There's probably still fewer than 2,000 people in Australia that have been prescribed a medical cannabis product legally. We don't know, but there's probably somewhere between 10 and 100,000 people using cannabis in their mind for a therapeutic reason.
Okay, can we say then that products with low THC are likely to be less addictive?
Probably, yeah. Well, it depends on what I mean by low THC. So, look, at the end of the day, let's be really clear. What matters is the dose of THC, not the proportion in the product. So what I mean by that is, you might have a 10-to-1 CBD product, or a 1-to-1, CBD to THC, a 10-to-1 CBD to THC, or a 1-to-1 CBD to THC. At the end of the day, the probable addictiveness of that medicine has to do with the total milligrams of THC consumed, not how much CBD was in it. So at the end of the day, it's probably the milligrams of THC consumed that matters. Less so what the other cannabinoids are doing.
Okay, we don't have any RCTs for the use of parachutes either, but people still use the darn things.
Yeah, I know. I'm not sure what that means. So yes, there are many things in medicine that are just standards of care. We don't have RCTs around should you do a clinical assessment when you first see a patient. That's just a standard of care. I don't think we should be equating the use of a medicine and the need for an evidence base around it as the same as it's a parachute. An anecdote is anecdote. I mean, look, guys, we can go and find lots of people out there that say, there's lots of snake oil salespeople as well. And if you hop on the internet, there is a lot of medical cannabis snake oil, heaps. In the health profession, we do need to sort of say, look, somewhere in this, we do need to look for an evidence base. So, you know, people saying that there's enough evidence out there, we don't need more evidence, do not understand how medicine interprets evidence. And the people who basically also then, you know, so that's the one end of the spectrum. We don't need any more research, the evidence is in. Well, sorry, if the evidence was in, then these products there would be no problem licensing these with the TGA. But the evidence required to license a medicine isn't there for most of these indications, At the other end of the spectrum, we've got a whole bunch of, you know, dare I say, should I call them slightly more conservative people, who are saying until we have all the evidence, you know, you should never even contemplate using it. And that's the other end of the spectrum. And look, it plays out very neatly if you look at the area of chronic pain, where the evidence is, you know, it doesn't matter who's reviewed it, studies are the same studies, they all end up with the same meta-analysis, they end up with the same, you know, odds ratios. And then it's not what, people don't dispute the odds ratio, people dispute how do you interpret it. So you have some pain experts are saying, the evidence is good enough for us to use it in pain treatment as a second-line therapy. You have other pain experts saying the very same evidence is not good enough for us to use it, and we should never use it until there's more evidence. So these are reputable pain experts, each looking at the evidence and coming up with different conclusions. So this is not parachutes. You know, I don't think we can just dismiss the introduction of a medication, you know, if we're talking about THC, one that has side effects, one that is dependence forming, and one that, you know, is not without its potential risks. You know, I think we do need to, you know, come up with an evidence base for it and not just say, well, you know, it's like, you know, it's completely harmless and people should just be able to buy it over the counter. That's an argument for legalization. I'm more than happy to engage in that argument, but it's a different set of questions to a doctor prescribing it for a medical indication. Let's not confuse those arguments.
All right, next question. Any developments on cannabinoid receptor blocking drugs for cannabis dependence treatment?
So some of you would be familiar, in the old days we had rimonabant, which was a CB1 antagonist. And there was a lot of interest in rimonabant. And indeed, James Bell and Mark Montebello, from memory, actually did a small study looking at rimonabant in cannabis dependence. Rimonabant actually got taken off the market. It got black boxed. There were some concerns around some of the side effect profile, and so no one's ever been able to get their hands on rimonabant again, and I don't think anyone will get their hands on rimonabant again in a hurry. I don't think it's being developed up. The cannabinoid antagonists are interesting. It's a little bit like what happens when you start playing with opioid antagonists. And it starts getting a little bit difficult because you have an endogenous opioid system. So when you start messing with that endogenous system, you start getting unintended effects, which is what the problem has been with rimonabant. It caused all these other symptoms that we weren't expecting. Is the problem with a lot of antagonists. It's kind of like you start prescribing it for one reason, but it causes other concerns. So naltrexone, you're familiar. One of the problems we have naltrexone is, dysphoria, gut problems in the first month, and a lot of that is, seems to be dampening down your opioid system. I think it's fair to say, guys, anyone who is holding out that the future of addiction treatment is an antagonist, a blocker, probably needs to go back and re-examine all the work that's been done in this area for other addiction drugs. In a nutshell, we have struggled to really bring any antagonist to market therapeutically and for it to have widespread uptake.
Okay, and final question. Sometimes even when we do have the evidence, use is still legal. For example, cigarettes and alcohol.
So we need to be separating then the idea of, and I really think we need to get our heads together around this one. I would like us to be able to talk about the difference between, the medical cannabinoids and where we're going as doctors, and how we're going to be thinking about the use of cannabinoids as medicine needs to be dissociated from illicit cannabis use. In the same way, we talk about people's oxycodone use, and we would never confuse that and with their heroin. We would, it's kind of, well, hang on, guys. Heroin and oxycodone are pretty different, in most ways. And that's what, that's how we should be thinking about medical cannabis and cannabis for other non-medical reasons. So we have an evidence that opioids work for certain medical conditions, but they are still illegal outside of medical reasons. Benzodiazepines are legal if a doctor prescribes them. They are illegal if not prescribed by a doctor. And none of us have got a problem with that. So why do we get confused with the cannabinoids? Why can't we have an evidence base and a drug which we use therapeutically as a medicine, but also recognize that some people go and use a similar drug for other reasons, for non-medical reasons. And I think we need to get better at differentiating those. So the evidence base we are talking about is, can we get an evidence for cannabinoids for epilepsy, cannabinoids for alcohol treatment, cannabinoids for pain? That probably doesn't have any bearing on a legalization argument for cannabis. Different discussions.